field, which provides her with a platform to continue to help in an inspiring way. She herself was diagnosed at 5 months old with sickle cell disease. For everyone around her, it posed an issue, but Fitz-Ann learned that it was an obstacle to overcome. She has been a part of various committees at SCAGO, such as the Education Committee alongside myself, and the Patient Advisory and Advocacy Council, and has always been an advocate for not only herself, but for every sickle cell warrior out there. I turn things over to you, Fitz-Ann, to take us through the next plenary.
Good morning, good morning. How's everybody this morning? Do I gotta do what I did yesterday? Energy, I need some energy. It's early. Thank you, there we go. So, as Delaney said, my name is Fitz-Ann Howell, and I want to thank you all for coming out this morning. I know it's early, and we're all tired, and it's a Saturday, but we're here to be educated, we're here to learn, and we're here to grow. So, housekeeping tips, just remember phones muted and keep the conversations to a minimum if possible. I know it's exciting topics, but we want to be able to hear what they're saying so we can ask the right questions. Again, the washrooms are located in the hall to my left, your right, and there is Wi-Fi, and at the end, I don't want Delaney to yell at me, so please remember to do your surveys. Please remember to do your surveys. Okay, so I will have our speakers come up on stage as I introduce them. So we have two speakers this morning. We have, Dr. Olanyii Ajisafe, who is a Toronto-based family physician with more than 2 decades of frontline experience in sickle cell disease care, a founding member of SCAGO. He has contributed significantly to the community education, advocacy, and efforts to strengthen awareness and early diagnosis. He currently serves as a physician lead at the Sickle Cell Clinic at the Black Creek Comprehensive Health Center, where he oversees clinical services, care, and coordination and program development. You'll also be hearing from Tanya and Elese, one of my very, very close friends. I'm not biased, I promise. So Tanya is a caregiver and a sickle cell advocate who serves as a SCAGO regional chapter lead for Southeastern Ontario, the secretary of SCAGO's Patient Advisory and Advocacy Council, where she helps me look good. I love that. She is deeply committed to the youth mentorship through SCAGO Youth Empowerment Program, and also serves as the chair of the Patient and Family Advisory Council at CHIO, contributing to systemic healthcare improvements for children and families. Tanya also holds a master's degree in project management and also works as a Canadian public servant. So I'll have my speakers come up and we can get started.
Good morning, everybody. It's so nice to see very early in the morning a lot of people. The room is full of people, and I'm sure we are here to learn about sickle cell. And it's very encouraging to see that, we have a mixture of everybody, And I can see there are a lot of youth here. It shows the importance of knowledge. And today, I just want to contribute a little bit to it. We've heard since yesterday about sickle cell disease. Every time sickle cell disease, which is very important. That's why we're all here. But again, how about the carriers? Have you thought of something that we can do that can prevent that sickle cell from happening? So my talk today is just to be around that sickle cell trait, about that carrier who now, if we can do things right, would not lead to having a sickle cell patient. So, what is sickle cell trait? Sickle cell trait just means an individual that has the hemoglobin A and another abnormal one, which is the S, hemoglobin S. When you have that combination, you have AS or AC, and that is the sickle cell trait. That is what we're going to focus on, and what can we do in terms of reproductive health to prevent people from having sickle cell disease patients. or individuals. So why is this important? I'm sure if I do a statistics here, we're going to see that majority of us, at least well, more than 200 here, maybe 10% of us will have the trait. That's how common this disease is. So 10% of the population in Africa, a century, the Mediterranean, Western Mediterranean, Middle East, and South Asia, they have this disease. I mean, this trait, not disease, sorry. And people sometimes are not even aware of that. And what is so funny is like 80% of these people that have, that is 80% of the 10%, actually don't know that they have it. For example, here, who can tell me, do we all know our sickle cell status here? Yeah, I can say some people don't even know my wishes. I mean, and they are not wrong because, you know what, this is not something that people talk about a lot and people just don't know. And sometimes we don't even know the importance of it. So, most of the time, when you know about this, it is when you have a child that has the sickle cell. So 80% don't know. Of the people that know, they know when it's too late, when they have had a child already. So that is why it is important. And those people that know do not know what they could have done differently to prevent that disease. So if you look at that now, so there's ignorance, there's regret because something happened and you don't know. And that could have been a prevention. So that is why it's very important for us to understand sickle cell trait, the carrier state, and what can we do. So at the end of this session, if you get something can be done about it, that's the order of story. That's just the summary of what I'm going to say. Next slide, please. So everybody's been talking, the last speaker spoke about the gaps, awareness gaps, and things like that. We have a lot of misconception. People think that sickle cell trait is sickle cell disease. People don't even know the difference. And it's very relevant for you to understand because it's only when you have the knowledge that you'll be able to know what to do about it. Primary care, you go to your doctor or your most responsible physician. It is clueless as well. It doesn't ask you questions that can lead to, oh, okay, I know what to do for you or something like that. When you are in that age group of making decisions, I do. So you are ignorant, you went to a doctor who is also ignorant. So how do we create that gap? How do we narrow it so that everybody, we have this consciousness, we have this awareness? Again, the government did something a little bit about it. Through advocacy, they are now doing newborn screening, which is great. Now we can detect, children that have a sickle cell. But how about those populations that have the trait? What happens to them? They are just lost in the go. We know that, this child has sickle cell and everybody knows about it. Okay, you go for this. But that child that had the trait, what happens? Nothing. We just know that that patient has it and nothing's done. So what is the government going to do about it? What can we do to make sure that this newborn screening is more relevant, is more, it is complete? You look at the whole picture. You look at the sickle cell trait. It looks at the sickle cell disease. And then, again, look at the cultural stigma. People think that, okay, it's not in my family. They're not getting tested. You just know that, they don't have this, like the former doctor said, in Africa, they talk about Ogbanje, Abikus. You don't have so many deaths in your family, so it doesn't concern me. It's not there. That's just ignorance. You need to be tested before you can say you don't have this trait or you don't have this disease. So that is why it's very important for us to create this awareness gap. We have to really close it. And that is why I'm going to talk about reproductive health. Next slide. So what is sickle cell trait? Like I said, we know a lot about this thing. And from my research, I will tell you a little bit about what I think happened or whatever. It's 1,000 years ago in Africa and all these places where there's malaria. people are dying and things like that, and nature had to do something about it. So what did nature do? Nature changed some of the protein in the lineage, the hemoglobin lineage. So it substituted one protein at number 6. It just changed that around. And that change brought about abnormality in that chain, and that led to the sickle, the S shape, the banana shape we are talking about. And why did nature do that? Because people are dying a lot from malaria. And you will know, if you have AS, you are a bit protected from malaria. That's what nature did. So we are seeing that that is why you see anywhere there's malaria, that is where you have this sickle cell thing. It's a mutation. It's just the change happened in those areas where there's malaria. That's why you can see it in Africa, you can see it in the Mediterranean, you can see it in the Middle East and South Asia. And that's why those malaria are. So it's a way that the nature is trying to protect so that people don't die from malaria. But what happened? We left it like that. Procreation started. People didn't take note of that. So as people that have SS or AC or something start to marry. And then that's why these things start to spread. So that is why, if you have that perspective, you understand why it is important to see that, you have the knowledge that can save you from this thing. Nature has done its own part. But what can we do about it ourselves so that we don't let this disease continue? And that is why it is very important. So it is asymptomatic. People don't know they even have it. Nobody can see, everybody looks normal. It's just the gene. And like I said, because you have the trait, that means you have the normal gene, you have the abnormal one. And you may not even notice anything, everything may be okay. The only condition, maybe you have exceptional stress or stuff like that, you could manifest a little bit, It could be like, you could lose a lot of muscle mass and stuff like that if you are exerting yourself. And sometimes they say that maybe medullary carcinoma, it can occur in people with sickle cell trait. And hematuria, you can see blood in your urine. Apart from that, you don't have anything. But what is most important is you can pass this abnormal gene into somebody else. That is why it is very important for you to understand sickle cell trait, how it affects and how it propagates sickle cell disease. Next slide. So, how does it do that? How does it propagate? How does it lead to sickle cell disease or stuff like that? When I say sickle cell trait, I'm talking of somebody that has the A and has the S. So just imagine, the man has AS. The wife has AS. What will be that match? What will it be? And you can calculate. Scientifically, it's very possible to calculate the outcome of that consummation, that marriage. What will happen? You will notice that 1 in 4 of that combination will lead to a child that has sickle cell anemia, SS. Then 50% of that consummation can have, that is half of that, can have AS. And then, luckily, 1 in 4 too can have AA. Nothing happens. If you look at that, again, if you have C, another trait, you could have AC, then you still have SC as well. So that range is still 25% of the SC, but most of them will be carriers. And so if you are lucky you even have a carrier, that is 50%, because chance of having 50% is more than 25%, supposing. That means you have 4 kids, all of them are AS. They're going to marry somebody again. If they are AS, can you see the chance now of you propagating SS? That is why it is important. That is why we have to talk about this, so that we understand, because there's something we can do about it. Next slide. So, what can you do about it? Like I said, there's a lot of ignorance in the health sector as well, because this disease, this kind of thing is not, it's falling to the Western world. It's something in the tropics, and that you are seeing something about this. It is because this thing is our disease. It happened in Africa and the Mediterranean where this malaria is endemic. It's not happening here. So the focus is not what is important here. You have other things that are important. That is why it is very important for us to champion this cause. That is why it is very important for us to be knowledgeable about it and do something about it. Now, in America, the American College of Obstetrics and Gynecologists, now they make it mandatory that when you are pregnant, you need to do your CBC and hemoglobin electrophoresis. They make it standard so that when you are pregnant, this is what you have to do, in addition to other things. So they are recognizing the importance of this thing, of this screening. It's not happening here yet. There are some other tests you can do, but the most important one is that hemoglobin electrophoresis. There is a high-performance chromatography you can do as well, but it's not as common. But for hemoglobin electrophoresis, that one will give you, whether you have AS or SC or something like that, you give all those things. There are some other tests you can do that. They call it solubility test, but that one excludes C. So it's not that important to do. But if you know that I want to go to my doctor, just know I can do. CBC is very common. You know, that's blood test that everybody does that. But hemoglobin electrophoresis. So make sure that when you go to your doctor and you are considering testing for this thing, that is the test you ask for. Hemoglobin electrophoresis. And so once you do that, then you know your status, because that will help you in making informed decision before you say, I do. Okay, next line. So before you go to, when you want to get married, I know that people go to the pastors, they tell them about, counseling, you get all those things too. Why can't we make sickle cell part of it? Why can't we now let the pastors to know a little bit about sickle cell and talk to the person that is getting married about sickle cell? So you are telling about counseling, how many children do you want to have, where do you want to live, all those kind of things. Why don't you make that a part of the discussion as well? We all have the opportunities to do that because advocacy is the most important thing, this thing. And we have all the avenues. We go to the churches, we go to mosques, we go to our social gatherings, we go to our clubs. But if you go to the marriage registry, those are all areas where opportunities are available, where you can talk about this thing. So people, because you have to create awareness. The moment you create awareness, then it leads to testing. After testing, it leads to counseling. So you are aware of your choices. Then, when you are making those choices, you are not making it because you are ignorant. You are making those choices because you are well informed about them. That is the importance of this talk. So, what can you do? Okay, you're in love, and you have the man you want to marry, and you went to test, and this man says, okay, it's AS, you are AS, and you still want to go ahead and get married. What are your choices? You could say, okay, yes, okay, we're not going to have children. No, marriage is not about children alone, right? You can say, okay, this is my decision. But you are making that decision because you knew, you are well informed about your chances of having a child that has sickle cell disease. So you are making that decision, it's an informed decision. Or you could say, you could go further and say, okay, you know what? We have this thing, we have this chance of doing. Can we get a donor egg or a donor sperm? And you watch it and then make sure that that sperm or egg does not have sickle cell gene in it. And then you procreate using that. Then you know your chances of getting a normal child that doesn't have sickle cell disease is guaranteed. That's a choice you can make. Or supposing you say again that, okay, you know what? I don't want to do that. I want to go to IVF route. You can do pre-implantation, genetic testing. You can do the testing of the gamete that you are going to plant when you are doing the IVF. So when you look at all these things, these are all options that are available for us to do when you're thinking about, okay, preventing this disease. And supposing now you blaze all the odds, now you are pregnant. Again, if you are even pregnant and you want to know whether you have a child that you are carrying a child that has sickle cell or not, you can still go to the doctor and get tested. When your pregnancy is between 10 and 13 weeks, you could get the coronavirus sampling. You could go to the doctor. They just do a little bit of, take a little bit of specimen through your cervix or through your abdomen, and they test it. Then you will know for sure this baby I'm carrying has the trait or has the sickle cell disease. And from that, you can make informed decision. That is why the testing is done between 10 and 13 weeks, so that you can do whatever you want to do if you know your child. And I've seen some people in my practice that said, okay, you know what, I've done the test for them, and they said, okay, you know what, I don't want this pregnancy. So you know that you are making that choice, that decision, because you are informed. You have done the test. Even if you miss the test at 10 to 13 weeks, even between 15 and 20 weeks, you still have the choice of checking your amniotic fluid and testing it and seeing whether you have the fetal gene has the sickle cell. So these are all opportunities we have to get to that decision-making process. But if you are not informed, if you don't know, you just don't get it done. And like some people tell me that, okay, you know what, these tests are invasive because you have to plant, you have to poke and stuff like that. And sometimes it can lead to the loss of the pregnancy. But the chance is very slim, no doubt, but it can happen. So there is a new test now you can do. It's non-invasive, it's just blood test. They take the sample of the mother and they can check the fetal gene there. And that one will help you to understand whether your child too has sickle cell disease or not. So, all these things are available. But if you don't know, you don't know. And that is why it is very important for us to understand that we can do something about this continuum of sickle cell disease by going through all these tests. Before you say I do, you go through all these things. And how can we do that? Next slide. We have to bridge the systemic gap that is there. The Canadian government, Ontario, has done well by doing the newborn screening, but we have to go beyond that. What do you do with the data? What do you do? Okay, this child has the sickle cell trait. Is the family doctor aware of that decision? That information? Is there any national data that says that, okay, all these things that are there and people can tap into it? If that patient leaves the province and goes to Alberta, is there continuation of care or is that information lost? So these are the questions we have to ask ourselves. It's unfortunate that the politician has left because these are the things that they need to know, that we are doing one thing, and I'm so happy that we are doing the newborn screening, but we have to go a step further. What do we do with that information? Now, this is a digital age. All doctors are using EMR. We can do it. We can do it in a way that doctors have access to the EMR, and it's programmed in it to remind them to do the test. So that when you go to your doctor at a particular time, you know that, oh, okay, my doctor will be able to do this test for me at a particular time. These are the things that we can do. And we know, again, most of the people, like this disease is an African thing, or people of it's not Canadian. When they come to this country, they come as adults. We miss that opportunity of newborn screening. So what is the next opportunity for them? They have to go to their family doctor to do the test. That is why we have to really work and advocate for all these things too, so that the government can be involved. When the government is involved, they make a policy. They say, okay, maybe between the ages of 18 and 35, you see your doctor and you do this screening. Just like you do mammogram at 50. You will say, okay, it's there. So when you do that, you just have to click on it and you do the test. Everybody now knows that, okay, I'm covered. Then you yourself, if you know that, okay, I'm going to get married and this has not been done, go to your doctor because you're on knowledge and tell him, I want to do this one. Most of the time, people tell the doctor, I want to do genotype. No, that's wrong. The gene is there in all cells of the body, but you have to be specific. Hemoglobin electrophoresis. So you have to tell your doctor, I want to do this, and then the doctor will be able to do that for you, and then you know your status. And from there, you'll be able to make your decision. Next down. So, what are you going to do? That's just the way I think we should do it. The clinical precision. The government is involved. The government knows that, okay, you are doing the screening and everything done. Then we have to refrain from the normal protective evolution adaptation. We address the stigma. When it's being talked of in the churches, in the mosque, everywhere, the stigma is removed. Nobody now say, oh, I don't want to know everybody to know my status because that is open secret. So we have to really demystify that kind of belief. And then the government needs to be involved. You use your EMR to get it in the system so that people know that, the doctors know that this is what I can do. The government comes in again and tries to educate the doctors, the physicians that are involved in this care, that, okay, I want you to do all these things too. You have to be knowledgeable. Because you don't blame them because this is not endemic here. So the information that people know when they are doing their training may be not as great as the one that is trained in Africa who lives with disease. So we have to educate. That knowledge gap has to be bridged. So these are all the things that the government can do. And then the family just don't say, hey, my family, they don't have it there. You go and get tested. Don't believe all these kind of things that, it's not there in my family. I asked my mother. So no. We are talking of evidence-based thing now. You ask and you do it. Next one. And so, what would be the thing? This is just a kind of illustration, but I may not, for time purpose, I won't be doing that. But go to the next one. So, the closing the gap has to do with the clinicians' knowledge. The clinicians need to be knowledgeable about this. The clinicians need to know what they are doing. They need to have that, okay, at so time, like I'm saying, 18 years to 35 years, I need to screen this patient for their hemoglobin electrophoresis. But that is the time they are going to be getting married. So you need to do that. The policymakers need to make the decision so that everybody knows, okay, they are much interested in it. And again, why are we here? We are doing this educational session because SCAGO is involved. Advocacy. Disseminating the knowledge. And I think maybe next year, I want to see the lab here doing free testing. This is a challenge to you, SCAGO people. Bring the lab here, let's do free testing. So everybody knows. It's an opportunity for us to do that. So these are all the things that we can do. And at the end of the day, we'll all be well informed. And from that information, we're able to make decisions that we're going to be able to be comfortable with. And through that process as well, decrease the incidence of sickle cell disease. Point on that, look into that, and think about it. We can do it, but knowledge is key. Thank you.
Good morning, everyone. Thank you for SCAGO for giving me the opportunity to speak at the summit today. And thank you, Doctor, for already paving the base for me to continue with what I will be talking about today. So my topic is barriers to sickle cell trait testing in Canada. And my name is Tanya, Elese. Like Fitz-Ann introduced, I'm the Southeastern Ontario Regional Lead for SCAGO. I have no financial or commercial benefit to disclose, although I recognize that I've been affiliated with SCAGO for the past 5 years, and we all know that SCAGO is one of those actively advocating for the sickle cell traits to be disclosed through the newborn screen program. Just to make sure. Okay. So the objectives today is we'll together identify patients, provider, and system-level barriers to accessing sickle cell trait testing and also existing sickle cell trait results in Canada. Examine gaps in testing, access, communication, and continuity of sickle cell trait status, including historical newborn screening results. We will explore what are some of the opportunities for clearer, more equitable, and patient-centered pathways to sickle cell testing and long life access to results. So the goal is to ask ourselves, we want to make it easier for anyone to know their sickle cell trait status. So what we know or may not know. Disease, we'll just take it as a game, let's say, because there's no name, it's anonymous, no right or wrong answer. So I believe everyone has their phone. We are in the intelligence era. So please scan and start with the test. I'll give you 1 minute, and then we can look at the result. So very quickly, we'll just see what we have, and it will help us better understand. Perfect. Okay. So do you know your own sickle cell traits? We see that in a room such like this, it's almost normal to see that a lot of people knows, but we see that there are some people that may not. Let's continue to the second. No, if you go back to, yes, just a second and maybe refresh. Or I don't know if people noticed that there were several questions. Okay, not a problem. But the second one was, if you have children, do you know their status? This is where we see that many people may know their status, but when it's come to the children or even the grandchildren, we may not know. The third question was, if you wanted to know your sickle cell status, would you know what test to ask for? And the doctor mentioned it. We sometimes are ignorant, and we don't know. Like we go to the doctor thinking that that's where we'll be finding the answer. And the last one was, if you wanted to find out, would you know where to start? Sometimes we just don't know. Like, if I even have been tested before, I don't know how to access it. So we can come back to the slides. Thank you, Dapo. So I wanted to share a little bit of my experience. One of my children, and I want to mention, if I'm stressed a little bit today, my husband and my kids are in the room. It's the first time I'm presenting in front of them. So one of my children was diagnosed with sickle cell disease at birth, and that made me think of Dr. Fasipe when she mentioned, like the slide with Pharrell, Happy Song, she mentioned the word hope. And it's funny because my son's name is Elikia, which means hope in Lingala, our language, but we didn't went through amniocentesis, so we didn't know that he would be born with a sickle cell, but already decided to name it Hope. And that's really strong for us. So he was born with the sickle cell, and we find out when he was 6 months old, like the diagnosis was confirmed. And at a certain point through the journey, I wanted to know the sickle cell trait status of my other two children, because I had a prior children before that and a last one. And I asked our family doctor that I wanted to know. And of course, she provided me with a requisition for a test. That's great. I went to CHIO, and ironically, CHIO, because we're coming from Ottawa, is just next door to the hospital where those kids were born, the Ottawa Hospital, next door. And it was on that same year that my baby was born, that I requested. And what I realized after is neither the family doctor nor the CHIO laboratory directed me toward the historical newborn screening result pathway. So I put that picture because that baby with those little toes was poked once when she got born to find out that she had or may not have the trait. But I have to bring her again to a facility, another poke, pulling the blood, bringing it back in a system that already had that information. And nobody told me that I could just go back and request for it. But what is even more puzzled is I had to ask. My family doctor knew that I had a child that has the disease. I was in that journey of understanding all that, but at no moment, and I know I loved her. Today, she retired. I loved her, and we received good care. But at no point there was that awareness, hey, maybe check your other kids if they have the trait or not. So I had to ask. I'm the one passing. So now when someone wants to find out if they have the disease, it's either, the trait, sorry, it's either I already have results, so they want accessing existing results. As I mentioned, historical newborn screening is one way. We know that this is not proactively shared, but it's still available. And also maybe medical record from another institution. You know, there's some paperwork that you need to do toward that. But usually is, who do I contact? How do I obtain it, even if it's existing results? The other way is I need to be tested. But again, some questions. What test should be requested? Who can order it? Where can it be done? And sometimes some people may also meet language, health literacy, and healthcare access barriers that we'll be talking about later. So the reflection for me was, is it easy for one to find out about the sickle cell trait status? So that look at public health systemic failure from what I think. I wanted to compare the prevalence between the prevalence versus the awareness gaps. There is a high carrier frequency going up higher and higher in Canada. We are in a global era today. There are a lot of mixing in the population. And we can see that 1 out of 118 Canadians are born with the sickle cell traits. On the other side, we have 1 out of 2,500 that are born with the disease itself. So that's 1 out of 118, match up to about 3,000 new carriers that are identified annually through the newborn screen program that may never know that they have. If we look at the asymptomatic blind spot, like Dr. mentioned, there's a 25% risk of passing on that disease if they are paired with another carrier. So the systemic failure that I wanted to stress here is there is a critical genetic data gathered at birth that remains locked away. They are leaving Canadian adults to discover the status reactively rather than proactively. Like we said, I have a child that has sickle cell, oh, that's where I find out. Okay, what about, do I keep this, like my family plans may be changing at that moment, or as we learned yesterday, there are still some complications that can happen that we see mainly just in people that have the sickle cell trait, and that's a important health information that one needs to have. So let's look closer to the barriers and gaps. I put them in 2 different categories, policy and systemic gaps, and social and cultural barriers. So the policy gaps, there's inconsistency screening. Newborn screening for hemoglobinopathies is not standardized or universal across every province and territory. This meaning that identification depends heavily on location, where you are located in Canada. If your province has a good program, then yeah, chances that you may go through the screening. Focus on disease of a trait, public health tracking system prioritize identifying the full disease, which is good. We want them to continue doing that. However, tracking and counseling for asymptomatic trait carriers are overlooked. There's the resource constraint. We have to recognize that today. Specialized clinical centers and genetic counseling services are limited, which creates long wait times and bottleneck access for confirmatory testing outside of major urban hubs. If we look at the social and cultural barriers, there's the stigmatization that was mentioned previously, concerns regarding social stigma, reproductive anxiety, and potential discrimination within specific cultural or marriage network that can discourage voluntary adult testing. And I heard someone saying, because they were already at that moment like close to engagement and heard me talking about sickle cell, and I was like, maybe it's a good idea for you, you know, and the other person to check, and they were like, oh, at this point. Yeah, but still, it helps you. I'm not saying disclose whatever you decide to do, to cancel whatever you decide to do, but at least you are informed. You know when things will happen. There's low awareness, general population and primary care provider awareness regarding the importance of knowing one's status for informed health decision remains low. And this leads to missed opportunity for screening in adults. So let's look closer to those missed opportunities. For me, I think not disclosing the sickle cell trait result through the newborn screening is a huge missed awareness opportunity for early education information for health decision and lifelong knowledge of sickle cell trait status. Better education of the general population or the primary healthcare providers can turn awareness into action, knowing where and how to request the appropriate tests. So knowing such important information as your sickle cell trait carrier status should not depend on how persistent you are, but rather on having a clear and equitable access to that information. I want to look closer to the two borders because I have 2 foot actually in those provinces. I was living in Quebec. I was because I just moved back to Ontario. But for the longest, I live in Gatineau, which is in Quebec. But my son is followed in Ontario at CHEO. So, and if you look at the 2 newborn screening program, both have the historical information. That's great. If the child is born in each of the province, they do have that. Who can access it? Great, again, the parents or the legal guardian, the healthcare provider, and even one as an adult. I'm 18 today. I know I've been born in Ontario and Quebec. You can reach out to the newborn program, screening program of your province and request for the status. But where things are a bit different, the newborn screening in Ontario will send the results to the healthcare provider, not to the parents. So you have to go through that channel, when the Quebec program will send it to the parent with information. I was thinking about that, and I really came back to say there is a barrier there. In Ontario, I need to go through the professional. In Quebec, I receive it. I believe at the points where I'm already reaching out to find this information, we are in the Google era, I've already started searching a little bit. So if I receive this status with the information, and I still feel that, no, this is too much for me, I need to better understand, I can reach out to my family doctor. And we know the reality today, both sides of the river. Family doctor is, oh my God, I just have it in French, une denrée rare. So it's rare, not everyone has that privilege today, even today, to have a family doctor. So I have to go through that channel. However, in Ontario, it's my only way to there. So there's, someone may say, oh, at the end of the day, forget about that, I won't continue. So let's come back to how can we close the gap. And I thought about patient-to-patient cycle. So the patient needs to know the sickle cell trait status. They go to the healthcare professional that need to know when and how to order, test, or access results. They move to the system, and that system needs to standardize the pathways. So me living in Campville, I have less chances to Mrs. Moji living in Toronto. We are all Canadian and need to have the same access. Screening program need to proactively and easily share the test result, the sickle cell test results, and we need clear guidelines and counseling on results. So we can see that it's good to have results, but it's good to understand them and also being able to access them. Very quickly, I have 1 minute left. I thought that it's good to raise the concern, the problem, but how can we bring solutions? So strengthen provider education. We need to equip health professionals to recognize when to retrieve an existing result, when to request testing, and when to proactively recommend sickle cell trait testing based on relevant ancestry family. We see that when you see your family doctor for the first time, they will ask you, is there cancer history in your family? Is there heart disease? Whatever. But if you know that you're meeting someone whose sickle cell is prevalent in that population, that should be one of the questions. Do we need to test that? Do you know? Maybe you need to test. Increase public awareness, empower individuals and families to understand sickle cell trait and recognize when to seek testing or access existing results. Make the pathway clear, ensure patients know where and how to access the test or results. improve access to results, reduce unnecessary provider and system barriers to sharing and obtaining the personal health information, and support communication and continuity. We want to ensure that people know their status, they understand the result, and they can retrieve it when possible through their healthcare journey. So I'm leaving you with the references I consulted and some resources that could be helpful. Again, there's a QR code that will bring you actually to that form and that document that you can save, share with your families. Like Dr. mentioned, we go to church, to mosques, to our community. We engage, but not every time we have the opportunity to stress a little bit, to stress that it is important to find out one status. Thank you very much.
Okay, we want to thank our wonderful presenters for their presentations today. So we're going to open up the floor to questions. Do we have any questions in the audience? Anyone?
Thank you very much for your informative sessions. I'm a nurse practitioner working at McMaster Hamilton Health Sciences. I work in the Lifespan Clinic. And I started working in the Sickle Cell Lifespan Clinic in February, having come from 13 years working in primary care. And as I look back through my years in primary care and getting reports back, or not even getting reports back, I worked in an NP-led clinic for 6 years, had my own roster of patients. What I see as a huge opportunity for SCAGO to look into regarding this education is looking into an education session through PriMed. PriMed is a yearly conference that's held here at the Toronto Convention Center in May. I think it would be a wonderful opportunity to do an education discussion event at that conference to inform the primary care providers in this province, both physicians and nurse practitioners. In addition to that, there is an organization called NP Circle. They do a lot of educational events for nurse practitioners. And if you're looking for information on how to connect with them to do these informative education events, please contact me. I'll be hanging out. My name is Cheryl Ticklar, and I'd be happy and very excited to see these two events come to fruition.
Thank you for that, Cheryl. We'll be definitely connecting.
Good morning, Dr. Ajisafe. Oh, that's okay. Okay. I just had a question for you. I'm Karen Fleming. I'm from Lake Ridge Health, and I'm working collaboratively with Durham Community Health Center to deliver services in Durham. And one of the things we do with our mobile van is we do community education and screening. And so my question to you, because you spoke about using the Sickle Dex versus hemoglobin electrophoresis, and you even identified the carrier status for AC. On a Sickle Dex, would carrier status for AC come up as positive? I'm curious. How does the Sickle Dex read AC at all? And if it doesn't, then to me that means we need to use the hemoglobin electrophoresis in order to pick up AC. So I'm just curious, does Sickle Dex show AC as just positive and not at all? Yeah.
No, it doesn't. And that is why I said the gold standard for now is the hemoglobin electrophoresis. You can do the HPLC, but that one may be a little bit specialized and it's not too common, but hemoglobin electrophoresis is key. Solubility desk will do the AC, but it will not discover AC. It will discover AS, but not discover AC. So that is why it's not even advisable to do it, because it may give you a false hope that, oh, I don't have this thing. Meanwhile, you have it. It was just not detected. So the go-to, the standard should be hemoglobin electrophoresis.
Hello, my name is Beverly Njuku. I'm a sickle cell warrior and advocate. I have kind of a comment that I'm trying to turn into a question in my head. I 100% appreciate and agree with the absolute need for everyone to be informed in terms of their sickle cell status and trait. I think there is so much stigma surrounding sickle cell disease, even to the point where people have been tested and told that they don't have the trait, and then they have a child with sickle cell. There's this thought that people need to, yes, know their status, but then terminate or not produce or things like that. And it's something that I just strongly want to step away from, because as someone living with sickle cell disease, I'm so proud to be alive. I don't at all blame my parents or anything like that. Thank you. I don't blame my parents. It's been a journey for everyone, of course, involved. And I think that we as a population are kind of holding ourselves back by saying this is, you know, an African disease. It's our disease that we need to fight. Because it's not true. It affects people of all races through genetics. So I guess my question is, do you think that there's a way that we could change that conversation in terms of finding a way to incorporate the work that we want to put on parents to make sure that you're not having a child with sickle cell disease, turning it to the work that we put on everyone else to working more towards the advancement of care for sickle cell disease, especially in today's world?
Yeah, I think you are very correct with this stigma around it. But again, we are here because we want to have information, knowledge. I think when everybody's knowledgeable about it, the stigma will go down. And how do we do that? Like, even your diagnosis, you are diagnosed and you go to a doctor, he diagnoses you. But now, if the government is involved and the government makes it like, oh, it's part of the thing. Before, when you go to your doctor at this age group, you do the test. That's already stigmatized, because then you don't feel like, oh, I need to let the doctor know what I'm doing, thinking of before he does the test, because the test now is standardized. You don't need to tell the doctor that I want to do mammogram, because when you are 50, automatically the government sends something to you. So if we can incorporate that, so most of these things should come from the government level and see, they can incorporate it, then it's easier. Because then you can go to your doctor, you know that you're going to have this test, and it's just like doing your annual. It's part of your annual test. So there's no stigma around it anymore. And it's just like I'm discussing with you, oh, you have diabetes. Okay, what are your options? It becomes just, that conversation becomes, so it's mystified. Again, if we're all talking about it, you go to the church, they're talking about it. You go to the mosque, they're talking about it. You go to your association, your local group, they're talking about it. Then, you know, everybody becomes comfortable. That, okay, this is not something that I need to hide myself from or not discuss with people. So this is the kind of thing. The more we create awareness, the better for us, because everybody now gets to know and gets to understand that, oh, this is just like any other thing, any other disease. Just like diabetes, just like hypertension. What do we do about it? The only difference is that hypertension is for maybe, okay, blacks to have a lot of say there. But this one is just only for a certain group of people, right? That's just the only difference. But we treat it like a disease that, you know, requires attention, that, you know, and we give that attention. So if we do that, I think it will help. So I think everybody should participate in that. Seek knowledge. The government is involved. Everybody is doing its own part. And sorry, and I want to speak to what the doctor said about SCAGO going to primary care. It's good, but the thing is, if you go, SCAGO is going there just as a group, as advocate. It will help a little bit, but can you imagine the government saying that this is what you have to do? It will have more weight because people are going to follow it. Because if a doctor goes to the SCAGO event, it's voluntary. It may see it as one of the sessions, oh, I don't even understand this. It doesn't gel with the doctor.
Or perhaps you can, there's so many specialists in this room who can propose to go and speak at the
Yeah, that is correct. But how about even primate makes it part of the agenda? That the primate himself recognizes that this is a topic, because they discuss diabetes every time. They discuss hypertension. But how about if primate says, okay, sickle cell too is important, without an advocate coming in, and primate makes it part of the agenda? So these are the things that we can do to change the narrative. Thank you.
Very quickly, I just wanted to, first, I am happy that you said you are happy to be here. And if we can celebrate again, we are all happy you're here. That's a very personal experience that I personally had, a personal experience, whatever. When my son was maybe at the time, it was still a baby, like it was our first in and out from the hospital because the protocol fever you have to get in. And I met a lady at the hospital at the time. We started talking, and she was coming for a son who has sickle cell as well. And talking, I mentioned to her the guilt. I said, at the time I decided to get married, at that time I already found out about my status, but still decided to move on. Still decided not to have an amniocentesis because I knew that I wouldn't stop that pregnancy, so there was no point for me. But there's that guilt. One thing she told me, remove that guilt, you gave that child an opportunity to come on this world. So I want people to understand that it's not always about saying we want a child to come or not. Reality is also those parents, when you go through, and we know that the sickle cell is I don't know if I may use this a spectrum, but you have some that will have more complications than others, more sicker than others, and it can be a huge burden, and if you're not prepared to go through that, it can break you. So that's why I was saying that it is important to make that informed decision. Okay, I know I have the trait. I know my husband has the trait, but we still decide to move on. Hey, again, that's French that come, attachons notre ceinture. So just buckle up. We know we're gonna go through up and downs, but we're gonna go through it. Unless than just finding out and being like, okay, do I get out of this car? That's what I wanted to mention.
So I know there's so many more questions out in the audience, but for time purposes, I'm being yelled at. We gotta hurry up. So it is now 11:20. We wanna take a second to thank our presenters for all their knowledge and all their information. So the things that we learned today, we need to standardize. Things need to be standardized. So who do I need to yell at after this? Okay. So